Welcome. In the previous session we have discussed about non-neovascular or dry AMD, and in this session we will be discussing about neovascular or wet AMD. We will be discussing about anti-VEGF trials in neovascular AMD in the next session. Neovascular AMD is characterized by macular neovascularization or MNV, from which fluid transudation, exudation mostly of lipids or bleeding result in loss of visual acuity, and left untreated or even following treatment, they may lead to end-stage fibrotic or disciform scarring, which irreversibly damages the central retina and retinal pigment epithelium and does not respond to further treatment. So we'll be discussing chiefly about exudative neovascular AMD, but there is another entity called non-exudative neovascular AMD, in which there is MNV which has not yet started to leak. Also there is another entity called exudative non-neovascular AMD, which is dry AMD without macular neovascularization but yet has subretinal fluid. In this photograph we see bleeding and exudation from macular neovascularization, and this photograph is of an eye with end-stage AMD with scarring as well as an area of atrophy. As we have discussed in an earlier session, macular neovascularization can be classified as types 1, 2 and 3. Type 1 MNV originates from the choroid, grows through the Bruch's membrane and lies in the subretinal pigment epithelial space and is the most common type of MNV. It loosely corresponds to occult CNV on fundus fluorescein angiography and results in fibrovascular or vascularized serous pigment epithelial detachment. We will be discussing further about occult CNV, fibrovascular PED and vascularized serous PED in this session. Type 2 MNV lies in the subneurosensory space and usually originates from the choroid, but may also originate as a type 3 MNV from within the retina, and it may be visible clinically as a grey-green membrane, and it loosely corresponds to classic CNV on fundus fluorescein angiography. Mixed type 1 and type 2 MNV lies in both subretinal pigment epithelial and subretinal spaces and is also called minimally classic CNV. We'll be discussing about classic CNV and minimally classic CNV further in this session. Type 3 MNV originates from the deep retinal capillary plexus within the retina and is also called retinal angiomatous proliferation or RAP. Exudation from this MNV usually occurs when they reach the subretinal or the sub-RP space, and it is usually associated with cystoid macular edema within the retina and serous PED, but subretinal fluid is less common with type 3 MNV. Symptoms of neovascular AMD includes decreased central vision, which is often sudden in onset, central or paracentral scotoma, metamorphopsia, and often micropsia. Clinical examination of neovascular AMD may show the membrane itself, but more commonly we find fibrovascular or serous PED associated with exudation and hemorrhage. So we may find a grey-green membrane or a pigment ring as seen here in this photograph with or without overlying subretinal fluid, particularly in type 2 macular neovascularization which lies in the subretinal space. Pigment epithelial detachment or PED in neovascular AMD is typically found in type 1 and type 3 MNVs, and the pigment epithelial detachment in neovascular AMD can be either serous, fibrovascular or hemorrhagic. Serous PED appear as a smooth, well-demarcated, dome-shaped elevation which is yellow-orange in color and sometimes is surrounded by a reddish halo as seen in this clinical photograph. Serous PED can be avascular or vascularized. Avascular serous PED, as shown here in this clinical photograph, is typically found in conditions such as central serous chorioretinopathy, whereas vascularized serous PEDs are associated with neovascular AMD, particularly with types 1 and type 3 MNV. In type 1 MNV, a notch in the margin of the PED may indicate the location of the type 1 MNV, and in type 3 MNV, a hemorrhagic spot anterior to the PED may locate the intraretinal site of the MNV. Type 1 MNV thus can present as a vascularized serous PED, but more commonly presents as a fibrovascular PED, which appears as an irregularly elevated lesion often associated with pigment, blood, lipid and fluid. And hemorrhagic PEDs, as seen here in this clinical photograph, may also occur with type 1 and type 3 MNVs, and sub-RPE blood in hemorrhagic PED appear darker red in color with smoother contours as compared with subretinal bleeding. In addition to the membrane itself or a PED in eyes with neovascular AMD, we may also find intraretinal, subretinal or sub-RPE hemorrhages, intraretinal or subretinal fluid and lipid exudates, and an elevated well-demarcated white or yellow sheet as seen here in this clinical photograph indicates end-stage macular scarring. Fluorescein angiography is still indicated in the era of OCT and Octa because OCT may not be able to differentiate between exudative neovascular AMD from exudative non-neovascular AMD, and Octa may fail to detect the MNV because of various reasons. Fluorescein angiography can characterize the MNV on the basis of its pattern of fluorescence and its location with respect to the center of foveal avascular zone. And in addition to MNV, fluorescein angiography can also characterize the associated pigment epithelial detachment. So far as the macular neovascularization is concerned, fluorescein angiography may characterize it as being classic, one of the three subtypes of occult or minimally classic MNV. It is very important to understand these terms and remember that they pertain only to the fluorescein angiographic appearance of the MNV. The fluorescein angiographic description of a classic CNV loosely correlates with type 2 or subretinal MNV and appears as a well-demarcated area of hyperfluorescence, bright and often lacy in appearance in early phase of the angiogram, which in the later phases of the angiogram shows increase in intensity of the fluorescence as well as leakage, and this is a very important description to remember. The fluorescein angiographically occult MNV loosely correlates with type 1 MNV, which lies in the subretinal pigment epithelial space, and it is better detected with ICGA as compared to FA because ICGA can better penetrate the overlying pigment and blood, and three subtypes of occult MNV has been described also based on fluorescein angiography. And we'll also find that the three subtypes of occult MNV are associated with clinically different types of pigment epithelial detachment. Two subtypes of occult MNV, fibrovascular PED and late leakage of undetermined source, show poorly defined area of hyperfluorescence appearing in mid to late phase of angiogram. So these two subtypes of occult MNV do not show fluorescence in the early phase of the fluorescein angiogram. Fibrovascular PED shows stippled hyperfluorescence at 1 to 2 minutes, which is the mid phase of the angiogram as shown here, followed by leakage or staining in the late phase of the angiogram as represented by this photograph. And clinically, fibrovascular PED is associated with an irregular RPE elevation. So fibrovascular PED starts demonstrating fluorescence 1 to 2 minutes after injection of the fluorescent dye, that is in the mid phase of the angiogram, and is clinically associated with an irregular RPE elevation. The late leakage from undetermined source or LLUS pattern does not show fluorescence either in the early or the mid phase of the angiogram, but shows a speckled hyperfluorescence only in the late phase of the angiogram and is clinically not associated with a pigment epithelial detachment. In these two angiograms from the same patient, this portion of the neovascular complex shows the speckled fluorescence pattern of LLUS, which occurs only in the late phase but is not detected in the early to mid phase of the angiogram. The third subtype of occult MNV is associated with the serous PED and so-called vascularized serous PED, demonstrating the typical fluorescent angiographic appearance of a PED with uniform homogeneous pooling of fluorescent dye within the well-demarcated area of the PED, along with a hyperfluorescent area located at a notch at the margin of the PED which locates the MNV. And so this subtype of occult MNV is associated clinically with a vascularized serous PED, which we have discussed earlier. In the minimally classic fluorescent angiographic pattern of MNV, an area of classic MNV type hyperfluorescence is surrounded by an area of occult MNV type hyperfluorescence as shown by these two serial angiograms of the same eye, with this area being classic in pattern, fluorescent early in the angiogram, and this area being occult in pattern, fluorescent later in the angiogram. Type 3 MNV was discovered much later after classic occult description of MNVs, and on fluorescent angiography, Type 3 MNV usually appears as a hyperfluorescent area at the crest and not the margin of a serous PED with or without associated cystoid macular edema. So in this photograph we see a hyperfluorescent area overlying a serous PED with this hyperfluorescent spot representing block fluorescence from this intraretinal hemorrhage. So we have already described the fluorescent angiographic appearance of the pigment epithelial detachment associated with an MNV, but we will describe it once more for clarity. So serous PED, both avascular and vascularized, show bright and diffuse hyperfluorescence with well-defined margins in the early phase and late pooling of the dye within that margin without any leakage. And for a vascularized serous PED, associated type 1 MNV is often found at a notch in the margin of the PED as shown here in this photograph, and associated type 3 MNV is often found at the apex or crest of the PED. Fibrovascular PEDs associated with type 1 MNV show stippled fluorescence in mid-phase with leakage or staining in the late phase of the angiogram, and hemorrhagic PED associated typically with types 1 and 3 MNVs show blocked choroidal fluorescence in all phases of the fluorescent angiogram, with fluorescence from the overlying retinal vessels being visible. ICGA wavelengths penetrate better through hemorrhage, pigment and lipid exudates and thus provide better visualization of type 1 MNV, which is the most common form of MNV. So in a type 1 MNV, fluorescent angiography is not able to detect the MNV itself, which ICGA can. And ICGA may show the feeder vessel of the MNV, which can be treated with photocoagulation if extrafoveal. Unlike as on fluorescent angiography where it appears poorly demarcated, type 1 MNV on ICGA appears as a well-demarcated area of hypercyanescence as shown here in these two photographs, appearing typically in the mid to late phase of the ICG angiogram, either as a hotspot of less than 1 disc area or as a plaque of more than 1 disc area, and usually located at the margin of a fibrovascular PED which appears hypocyanescent on ICGA. ICGA can also differentiate between type 1 MNV from aneurysmal type 1 MNV, which is also known as polypoidal choroidal vasculopathy, and which we will discuss with the pachychoroid spectrum of diseases. As we have discussed earlier, type 2 MNV is well seen on fundus fluorescent angiogram, and so ICGA is usually not done in this situation, but ICGA may provide a better visualization of the MNV with early phase showing a discrete neovascular network with a dark rim. And as there is no leakage of ICG dye from either type 2 or type 1 MNV, more accurate delineation of the network is possible as compared to fluorescent angiography. And ICGA may differentiate between immature choroidal capillaries and mature larger choroidal vessels in the neovascular network, which may have therapeutic implications as we will discuss with Octa. Type 3 MNV on ICGA appears as a hotspot with late leakage and staining as seen here in this angiogram, which may lie over a serous PED which appears hypocyanescent in ICGA. And ICG video angiography can identify the characteristic dye filling pattern of type 3 MNV, in which there is sequential filling of at least one retinal arteriole, which then descends into deeper retina to a vascular communication and then draining into at least one retinal vein. And later in the natural history of type 3 MNV, retinochoroidal anastomosis may be detected on ICGA. So ICGA is more efficient than fluorescent angiogram in detecting MNV types 1 and 3, and this is important to note. And as we have mentioned, pigment epithelial detachments appear as an area of relative hypocyanescence on ICGA as compared to the background. And as we have discussed, associated type 1 MNV is often detected at a notch in the margin of the PED, and associated type 3 MNV is often detected at the apex or crest of the PED. And in advanced neovascular AMD, retinochoroidal anastomosis may be detected on ICGA, which are usually associated with preretinal or intraretinal hemorrhage clinically and intraretinal leakage on fluorescent angiography. Presently, optical coherence tomography plays a central role in the diagnosis and management of neovascular AMD, and optical coherence tomography may be able to detect and characterize the MNV network itself, the associated pigment epithelial detachment, presence or absence of intraretinal or subretinal fluid, and demonstrate biomarkers suggesting activity or inactivity of the MNV. Type 1 MNV appears as a hyperreflective material in the sub-RPE space as shown here in this photograph, and is usually associated with a pigment epithelial detachment which can be shallow and irregular in case of fibrovascular pigment epithelial detachment as seen here in this photograph, or large and serous in case of vascularized serous PED. The MNV usually lies underneath a fibrovascular PED as shown here in this photograph, or at the edge of a vascularized serous PED, and in long-standing cases, a fibrovascular PED may appear multilayered. Type 2 MNV lies in the subretinal space and is one of the etiologies of subretinal hyperreflective materials or SHRM as seen here in these two photographs. And type 2 MNV can be associated with subretinal and intraretinal fluid as seen here in this photograph. The most common findings on OCT of type 3 MNV are a serous PED with or without cystoid macular edema as seen here in this photograph. An intraretinal hyperreflective lesion overlying the PED usually indicates the location of the type 3 MNV, and a downward deflection of the outer plexiform layer called the steer sign as seen here in this photograph is typical of type 3 MNV. This photograph also shows a type 3 MNV with a serous PED, cystoid macular edema, and a hyperreflective lesion overlying the serous PED. This hyperreflective area underlying the retinal pigment epithelium suggests the presence of the MNV in the sub-RPE space extending from the intraretinal space in case of a type 3 MNV. On optical coherence tomography, both avascular and vascularized serous PED appear as a dome-shaped elevation of retinal pigment epithelium with a smooth contour, and the subretinal pigment epithelial space appears hyporeflective. Posterior to this hyporeflective space, the Bruch's membrane can be discerned as a thin hyperreflective line. In a vascularized serous PED, associated type 1 MNV may be detected at the margin of the PED, and associated type 3 MNV may be detected at the apex of the PED. Fibrovascular PED appears as an area of shallow RPE elevation with an irregular contour, and it may demonstrate lacy or polyp-like hyperreflectivity attached to the undersurface of the retinal pigment epithelium. Chronic fibrovascular pigment epithelial detachments appear multilayered as seen here in this photograph due to cholesterol deposition, and this is called onion sign. On OCT, hemorrhagic PED has a shape similar to serous PED but is often more acute as seen here in this photograph, and there is hyperreflectivity in the sub-RPE space along the retinal pigment epithelium. Posterior to this hyperreflectivity, there is shadowing. On OCT, intraretinal fluid can vary from mild thickening of the outer nuclear layer to cystoid macular edema as seen here in this photograph, which appears as round hyporeflective spaces in the outer nuclear layer or inner nuclear layer. Lipid exudation appears as hyperreflective dots in the outer retina, which may surround the cystic spaces called the pearl necklace sign. Intraretinal fluid is more common with type 3 MNV and is a biomarker of poor visual outcome in eyes with type 1 MNV. Subretinal fluid, as the name suggests, is found between the retinal pigment epithelium and the neurosensory retina, and when the fluid is serous, it appears as a homogeneous hyporeflective space as seen here in this photograph. But when the subretinal fluid contains proteinaceous exudation, the space appears to be split by fibrinous membranes, and subretinal fluid is more commonly found with types 1 and 2 MNV but is less common with type 3 MNV, and subretinal fluid has not been associated with a poor visual outcome. Subretinal hyperreflective material is an OCT finding of a hyperreflective band in the subretinal space, which can be either subretinal pigment epithelial or subretinal in location. Active SHRM has an ill-defined contour as seen here in this photograph, and inactive SHRM has a more well-defined contour. SHRM can be due to the MNV itself or due to exudation, fibrin, or hemorrhage. An octa may help in differentiating MNV from the other etiologies of SHRM. And SHRM involving fovea, a large SHRM, and SHRM with well-defined contours are predictors of poor visual prognosis. OCT signs of activity in neovascular AMD include onion sign, which we have discussed and as seen here in this photograph, SHRM, which we have also discussed, bacillary layer detachment as seen here in these two photographs, which is a separation between the myoid and the ellipsoid zones of the inner segment of the photoreceptors, bridge arch-shaped subretinal fluid, which is a bow-shaped neurosensory detachment with steep angles, along with adhesions between the neurosensory retina and the underlying MNV, which is typically a chronic type 2 MNV with scarring. The subretinal fluid does respond to anti-VEGF, but the visual prognosis is usually poor. Other OCT signs of activity in neovascular AMD include a prechoroidal cleft, which appears as a hyporeflective space in the sub-RPE region located anterior to the Bruch's membrane and posterior to usually a multilayered sub-RPE material. And this indicates significant disease activity and requires intensive anti-VEGF therapy to preserve vision. Sub-RPE hyperreflective column, which appears as a narrow hyperreflective column beneath the RPE as seen here in this photograph, and which indicates weakened or cracked RPE through which fluid, blood or vessels can migrate from the sub-RPE space to the subretinal space. And RPE tears or rip, which we will discuss along with the other complications of neovascular AMD. OCT signs of inactivity in neovascular AMD include disciform scarring, which we will discuss along with the other complications of neovascular AMD, outer retinal tubulations, which we have discussed in the previous session, and central posterior hyaloid fibrosis as seen here in this photograph, which is a thickened and unusually adherent posterior hyaloid at the foveola, resulting in filling in of the foveal pit, and it occurs with chronic type 2 MNV with extensive subretinal fibrosis. OCT plays a crucial role in monitoring response of neovascular AMD to therapy by assessing presence of fluid, either qualitatively by analyzing the OCT-B scans or quantitatively by analyzing retinal thickness maps, and this is particularly important in PRN anti-VEGF regimens. On follow-up, intraretinal fluid should be differentiated from outer retinal tubulations, which we have discussed in the previous session, because outer retinal tubulations do not respond to anti-VEGF therapy and are a biomarker for poor prognosis. If pigment epithelial detachment is present, volume and area of PED can also be serially analyzed as a marker of activity of neovascular AMD. Optical coherence tomography angiography or OCT angiography is a non-invasive tool to detect the neovascular network, guide treatment decisions, and quantitatively monitor activity. But signal attenuation due to a large PED or a low flow state of the MNV may make it challenging to detect the neovascular network with OCTA. This is particularly so with treatment-naive MNV, which have capillary-like immature vessels with low blood flow within them, which are difficult to be detected by OCTA. On OCTA, type 1 MNV typically is found initially at the edge of a vascularized PED, and both type 1 and type 2 MNV can be morphologically characterized by their shape, by their margins, whether distinct or indistinct, and by their constituent blood vessels, whether they are immature, mature, or hypermature. There are also other morphologic characteristics which have been associated with exudative activity. Immature vessels, as seen in this OCTA image, consist of fine capillary proliferation in a treatment-naive MNV, which usually has a low blood flow but respond promptly to anti-VEGF therapy. And mature vessels, as seen here in this OCTA image, develops following anti-VEGF therapy of a treatment-naive MNV, appear to have larger, thicker vessels with higher blood flow but is more resistant to anti-VEGF therapy. Type 2 MNV, as we have mentioned, can be similarly morphologically characterized as type 1 MNV by OCTA, and OCTA can differentiate type 2 MNV from type 1 MNV by accurate segmentation, which we have discussed in the session on OCTA. And OCTA can differentiate type 2 MNV from other etiologies of SHRM detected on OCT. On OCTA, type 3 MNV appears as an intraretinal flow signal in the outer retina, and serial OCTA can demonstrate posterior downgrowth of type 3 MNV to the RPE before serous PE deformation. Type 3 MNV has been shown to respond better with anti-VEGF as compared with types 1 and 2 MNV. Octa does not demonstrate leakage of MNV as compared to fluorescein angiography, which is very important to remember, and Octa biomarkers which suggest activity of MNV is listed here. But these Octa biomarkers have not yet been uniformly included in routine clinical practice. On Octa, pigment epithelial detachment appears as a hyporeflective area as shown here in this photograph. On Octa, choriocapillaris flow deficits, which we have discussed in the previous session, are increased in eyes with neovascular AMD but not as severely as compared to eyes with non-neovascular AMD. And among the various types of MNV, eyes with type 3 MNV and their fellow non-neovascular eyes have more severe choriocapillaris flow impairment as compared to type 1 and type 2 MNV eyes and their fellow non-neovascular eyes. Octa is also useful to diagnose non-exudative neovascular AMD by detecting MNV in these eyes, which are prone to develop future exudation, and also to diagnose exudative non-neovascular AMD by ruling out MNV in these eyes, thus avoiding unnecessary treatment. Macular photocoagulation study showed a 35% risk of the fellow eye of an eye having MNV to develop MNV within 3 to 5 years, and ARED showed a 43% risk of patients with unilateral advanced AMD to develop advanced AMD in the fellow eye within 5 years, with advanced AMD including both geographic atrophy and macular neovascularization. Risk of further vision loss can be reduced with micronutrient supplementation, lifestyle modification, particularly smoking cessation and weight reduction, monitoring with Amsler's grid and PHP, which we have discussed in an earlier session, and regular follow-up along with immediate reporting of a new onset or further visual worsening. And we have discussed the high-risk OCT features of early AMD, increasing the risk of late AMD, which includes non-homogeneous internal reflectivity of drusen, hyperreflective foci within outer retina, which suggests RPE migration within the retina, higher drusen volume, subretinal drusenoid deposits, and choroidal hypertransmission. Differential diagnosis of neovascular AMD includes other causes of macular neovascularization such as pathologic myopia and angioid streaks, central serous chorioretinopathy with or without pigment epithelial detachment, macular telangiectasia type 2, polypoidal choroidal vasculopathy, and retinal arterial macroaneurysm, along with other causes of macular hemorrhage. The history of management of neovascular AMD can be divided into a pre-anti-VEGF era when treatment was initiated with the hope of preventing further vision loss, and the current anti-VEGF era when treatment is initiated with the hope of visual gain. And the treatment modalities available in the pre-anti-VEGF era, namely laser photocoagulation, photodynamic therapy, and submacular surgery, are considered obsolete presently, except photodynamic therapy for polypoidal choroidal vasculopathy. Macular photocoagulation study showed that laser photocoagulation of classic extrafoveal MNV reduces further loss of vision but has a high risk of recurrence of the MNV and a risk of inadvertent injury to the foveal center with the laser. Photodynamic therapy with vertiporfin resulted in occlusion of blood vessels by irradiating intravascular vertiporfin, a photosensitizing agent which was administered intravenously, followed by irradiation with a specific laser limited to the area of the MNV. The TAP study evaluated the efficacy of PDT in subfoveal predominantly classic CNV, and the VIP study evaluated the efficacy of PDT in subfoveal occult CNV, and both showed a lower rate of vision loss as compared to placebo. Submacular surgery trial showed no benefit on visual outcome of removal of neovascular membrane, and efficacy of macular translocation surgery is controversial. In macular translocation surgery, the foveal area of neurosensei retina was separated from diseased zone of RPE and shifted or translocated to a zone of healthy RPE. Anti-VEGF therapy is considered as the gold standard therapy for exudative neovascular AMD, and it has been shown that untreated More than half of all eyes with neovascular AMD will have a vision of 20 by 200 or worse within 3 years. But with anti-VEGF therapy, more than 90% of patients will maintain stable vision and one-third will have visual improvement in this time frame. And when we discuss the anti-VEGF trials in the next session, we'll find that these two figures are consistently maintained by most of the studies. The VEGF family of molecules include VEGF-A, B, C, D and placental derived growth factor. VEGF-A is of major importance in pathophysiology of neovascular AMD, and this is very important to remember. Often VEGF refers to VEGF-A itself. And VEGF-A is encoded by a single genetic locus on chromosome 6, and differential exon splicing of this gene result in several isoforms, with the VEGF-A165 isoform being the most potent. These numbers actually reflect the number of amino acids in the VEGF-A protein isoform. But what is more important is non-selective blockade of VEGF-A isoforms is crucial for maximal therapeutic effect in neovascular AMD instead of targeting a single VEGF isoform, and this is also very important to remember. The main physiologic pathway is VEGF-A acting on VEGF-R2 receptor, and through this pathway VEGF-A promotes both angiogenesis and vascular hyperpermeability, and this is very important to remember. VEGF-B and PDGF also promotes angiogenesis, and aflibercept, one of the anti-VEGF drugs, also target VEGF-B and PDGF in addition to VEGF-A. Vasculogenesis is the formation of new blood vessels from precursor cells, whereas angiogenesis is the formation of new blood vessels from already existing blood vessels. Steps in angiogenesis are as follows. Hypoxic cells produce angiogenic factors, which is very important to remember. And the angiogenic factors include vascular endothelial growth factor, angiopoietin 2 and fibroblast growth factor. Angiopoietin 2 is targeted by faricimab, one of the anti-VEGF drugs. Angiogenic factors attach to endothelial cells, following which pericytes detach from the blood vessels, and then the endothelial cells start proliferating. The proliferating endothelial cells grow towards the source of VEGF and secrete matrix metalloproteinase, which destroys the extracellular matrix. The proliferating endothelial cells then form new vessels with lumen, following which endothelial cells stop proliferating, extracellular matrix is deposited, and pericytes are re-recruited to stabilize the blood vessels, resulting in maturation of the vessels. As we have mentioned, in addition to angiogenesis, VEGF-A also mediates increase in vascular permeability by activating the VEGF-R2 receptor, which causes calcium influx, leading to nitric oxide synthesis by endothelial nitric oxide synthetase. Pegaptanib was the first anti-VEGF drug to be approved for neovascular AMD and is a pegylated polynucleotide RNA aptamer which specifically binds only to isoform 165 of VEGF-A, and pegaptanib is no longer used because of improved efficacy of the other anti-VEGFs, which, unlike pegaptanib, non-selectively block all isoforms of VEGF-A. Pegaptanib is thus an RNA molecule and not an immunoglobulin or immunoglobulin fragment, as are the currently available anti-VEGF molecules. These are the diagrammatic representations of the currently available anti-VEGF molecules, with their molecular weights being given in the associated label. Ranibizumab is a recombinant Fab fragment of monoclonal IgG1 which binds and inhibits all biologically active isoforms of VEGF-A. So the ranibizumab molecule structurally corresponds to one of the two variable regions of a full immunoglobulin molecule. So ranibizumab has one antigen binding domain per molecule. We may note here that all anti-VEGF molecules bind to VEGF-A molecules and does not act by blocking the VEGF-R receptor. Bevacizumab is a full-length IgG1 antibody as shown here in this diagram with two antigen binding domains per molecule which selectively bind and inhibit all isoforms of VEGF-A. So it is a larger molecule as compared to ranibizumab with longer intraocular and systemic half-life. Bevacizumab has not been approved by FDA for intraocular use but is used widely off-label because of its low cost. Aflibercept, as represented by this diagram, is a recombinant protein composed of extracellular ligand binding domains of human VEGF receptor 1 and human VEGF receptor 2 attached to an Fc fragment of IgG1 and so-called VEGF receptor decoy or VEGF trap. So if we compare the structure of aflibercept with that of bevacizumab, the Fc fragments are similar, but aflibercept does not contain the FAB fragments of a complete immunoglobulin molecule, and instead of these two FAB fragments, aflibercept contains the extracellular ligand binding domains of human VEGF receptor 1 and human VEGF receptor 2. And since it contains VEGF receptor 1 in addition to VEGF receptor 2, aflibercept binds to both VEGF-A as well as VEGF-B and placental growth factor, which, as we have discussed, also contribute to angiogenesis through VEGF receptor 1. Brolucizumab is the smallest among the anti-VEGF molecules and is a single-chain antibody fragment which targets the major isoforms of VEGF-A. So if we compare the structures of ranibizumab and brolucizumab, which are both immunoglobulin fragments, the structure of brolucizumab corresponds to this portion of ranibizumab molecule, and the small molecular weight is said to contribute to better retinal penetration of brolucizumab in comparison to the other anti-VEGF molecules. Faricimab is the latest among available anti-VEGFs to be approved and is a bispecific monoclonal IgG1 antibody with one antibody fragment binding and inhibiting VEGF-A and the other antibody fragment binding and inhibiting angiopoietin-2, which also contributes to angiogenesis. So among the currently available anti-VEGF molecules, bevacizumab and faricimab are complete immunoglobulin molecules, while ranibizumab and brolucizumab are FAB fragments, and aflibercept is a combination of VEGF-R receptors along with Fc fragment of immunoglobulin. We will be discussing about the anti-VEGF trials in the next session. 3 regimens for anti-VEGF administration has been described, and they are fixed interval dosing, PRN or pro-rata dosing, and treat and extend dosing. In fixed interval dosing, ranibizumab is administered once every 4 weeks, while aflibercept and brolucizumab are administered once every 4 weeks for 3 doses, followed by once every 8 weeks. In pro-rata regimen, also known as PRN regimen or as needed regimen, following an initial loading dose of once a month injections for the initial 3 months, monthly follow-up is performed with clinical evaluations and OCT examinations, and anti-VEGF injections are administered only when there is disease activity detected on OCT. And several trials comparing PRN with fixed interval dosing found fixed interval dosing to have a better final outcome. In the treat and extend regimen, also known as T&E regimen, following the initial loading dose of once a month injections for the initial 3 months, intervals between successive examinations are increased by 2 weeks if evaluation shows no disease activity up to a maximum of 12 weeks, and injections are given at every such visit whether or not OCT examinations demonstrate disease activity, and if at any of these visits OCT examination show recurrence of disease activity, the subsequent examination intervals are shortened by 2 weeks. Trials have demonstrated non-inferiority of T&E regimen as compared to fixed interval or PRN regimens. So in PRN regimen, the number of injections are reduced, but the number of visits are not reduced as compared to fixed interval dosing, whereas in treat and extend regimen, both the number of visits and the number of injections are reduced as compared to fixed interval dosing regimen. Common but not serious ocular adverse effects of anti-VEGF injection include subconjunctival hemorrhage, floaters, corneal abrasion, and silicone oil droplets in vitreous cavity. The source of the silicone oil is the silicone oil used to polish the tip of the cannulas and needles. Rare and serious ocular side effects of anti-VEGF therapy include endophthalmitis, which has an incidence of 1 in 2000 injections, and povidone iodine for 30 seconds prior to injection is recommended as prophylaxis, but preoperative and postoperative topical antibiotics are ineffective in preventing endophthalmitis and may be harmful by promoting the growth of resistant organisms when used repeatedly for repeated injections. Other rare and serious ocular side effects are RPE dip, which we will discuss along with complications, traumatic cataract, sterile inflammation, retinal tear with or without retinal detachment, vitreous hemorrhage, and increased intraocular pressure. Sterile inflammation is known particularly to occur with brolucizumab injection, and there is no definitive evidence of increased incidence of systemic thromboembolic events following anti-VEGF therapy. Older age, lower baseline visual acuity, and larger MNV lesions at baseline are poor prognostic markers of response to anti-VEGF therapy, and presence of foveal pit, an undisturbed ellipsoid zone, and absence of SHRM in the foveal center are good prognostic markers. Presence of intraretinal fluid or cystoid macular edema at baseline or final visit are associated with poor outcome, but persistence of subretinal fluid, as we have discussed, at final visit is not associated with a poor visual outcome. RPE abnormalities in the form of hyperpigmentation or atrophy, which appear as areas of hyperautofluorescence and hypoautofluorescence respectively on fundus autofluorescence, are associated with a poor outcome following anti-VEGF therapy, and absence of leakage from the neovascular lesion on fluorescein angiography is a predictor of poor response to anti-VEGF therapy. Certain opta markers such as closed circuits, peripheral loops, or capillary fringes are associated with a poor outcome, and as we have discussed, type 3 MNV responds better to anti-VEGF therapy as compared to types 1 and 2 MNVs. And polymorphisms in CFH, ARMS2, ApoE, and VEGF genes are associated with sustained neovascular exudation and a poor final outcome. With appropriate anti-VEGF therapy, 10% of patients lose 15 or more letters within 2 years, but the 7-up study showed that the long-term prognosis even following anti-VEGF therapy is relatively guarded. 34% of eyes of Medina and Anchor trial patients who were followed up for 7 years had a visual loss of 15 or more letters from baseline. For those with bilateral central vision loss, visual modes of rehabilitation include magnification, increasing contrast, and brighter illumination, which we have discussed in the previous session. And non-visual modes of rehabilitation include audiobooks and social and psychological support. Complications of neovascular AMD include subretinal hemorrhage, RPE tears, macular atrophy, and scarring. Patients having subretinal hemorrhage following neovascular AMD present with a sudden and a severe loss of vision and rarely may complain of pain. As we have discussed earlier, subretinal hemorrhage appear brighter red with an irregular or scalloped margin, as seen here in this clinical photograph, while sub-RPE hemorrhage appear darker red with more well demarcated and usually round margin, as seen here in this photograph. An association of subretinal hemorrhage in neovascular AMD patients has not been associated with intake of aspirin, so aspirin therapy is not contraindicated in patients with AMD. Optical coherence tomography in subretinal hemorrhage shows the position and extent of the subretinal blood. Fluorescein angiography shows blocked choroidal fluorescence with visualization of the overlying retinal vessels, and Indocyanine green angiography may be able to demonstrate the underlying MNV because the excitation and emission wavelengths of ICGA has a better penetration to blood. Non-surgical therapy of subretinal hemorrhage, which does not involve vitrectomy, include pneumatic displacement of the blood with either C3F8 or SF6 intravitreal injection with or without intravitreal injection of tissue plasminogen activator, followed by face down positioning for 3 to 5 days. And it has been seen that pneumatic displacement with intravitreal tissue plasminogen activated is capable of displacing the submacular blood if injected within 2 weeks of onset. Often intravitreal anti-VEGF injection is also added with pneumatic displacement and TPA. And surgical therapy of subretinal blood involves vitrectomy with injection of subretinal tissue plasminogen activator with or without subretinal anti-VEGF, followed by pneumatic retinopexy. But surgical drainage of subretinal hemorrhage is no longer recommended, as is surgical removal of the neovascular membrane. And vitrectomy is also required for breakthrough of subretinal blood into the vitreous cavity. Retinal pigment epithelial tears usually occur with fibrovascular PED with an underlying type 1 MNV, and it is more common following anti-VEGF injection, which is very important to remember, particularly in pigment epithelial detachments with height more than 500 microns and usually within 3 months of starting anti-VEGF injections. And this is said to occur because anti-VEGF therapy results in contraction of the underlying macular neovascular network present beneath the fibrovascular PED. And retinal pigment epithelial tears can be complicated by severe macular hemorrhage. RPE tears more than one disc diameter in size and crossing fixation have poor visual outcome. This clinical photograph shows an RPE tear, with this being the tearing margin and the bare choroid being visible under the torn area, and this is the scrolled edge of the torn RPE. On fluorescein angiography, intense transmission hyperfluorescence is found from the bare choroid, and blocked choroidal hyperfluorescence is found in the region of scrolled up RPE. On the other hand, in fundus autofluorescence, the region of bare choroid shows hypoautofluorescence because RPE with liposuction is not present in that region, and hyperautofluorescence is found in the region of the scrolled up RPE. In acute stage of a retinal pigment epithelial tear, OCT shows a tented up PED with scrolled and corrugated retinal pigment epithelial layer and shadowing underneath, and the MNV may be found attached to the torn portion of the RPE. So this is the torn portion of the RPE which was originally attached to this portion of the Bruch's membrane, and the adjacent area which is thus devoid of RPE shows choroidal hypertransmission. An area of photoreceptor and RPE loss in neovascular AMD is called macular atrophy, and the term geographic atrophy is restricted to such an area in non-neovascular AMD. Macular atrophy is a common cause of vision loss in MNV eyes after long-standing anti-VEGF therapy, and the Harvard study found that presence of subretinal fluid is negatively associated with future occurrence of macular atrophy. Macular scarring is proliferation of fibrous component of an MNV with regression of its vascular component, and it appears as a well-demarcated elevated whitish or yellowish lesion in which hyperpigmented areas can also be present, as seen here in this photograph. And occurrence of macular scarring is associated with a significantly worse visual acuity as compared to regression of the MNV without macular scarring. Macular scarring may show blocked fluorescence in the early phase of a fluorescein angiogram and characteristically shows staining in the late phases of the angiogram. On OCT, macular scarring appears as a highly reflective thickened lesion in outer retina and or the subretinal space. Outer retinal tubulations, as seen here in this photograph, which we have discussed in the previous session, can be present in the retina overlying a macular scar. In an eye with disciform scarring, usually intraretinal and subretinal fluid is not found, and persistence of subretinal or intraretinal fluid indicates activity and guides retreatment. Opta shows that some perfusion is present in a macular scar, but it is much less as compared to regression of MNV without macular scarring. And fundus autofluorescence shows a hypoautofluorescence area in the region of macular scarring due to RPE atrophy. Non-exudative neovascular AMD refers to an eye where a macular neovascular network is present but from which exudation has not yet started. The MNV in this situation is typically type 1 or sub-RPE in nature and can be detected on Indocyanine green angiography and Opta, but without any clinical or OCT evidence of bleeding or exudation. Opta has the highest sensitivity to detect non-exudative neovascular lesions, and it has been seen that 30% of patients with clinically intermediate AMD have MNV type 1 lesions on Opta, and there is a significant risk of conversion to exudative AMD with a 21% risk of conversion to exudative AMD within 1 year of detection of a non-exudative neovascular lesion. Exudative non-neovascular AMD refers to the presence of subretinal fluid in an eye with intermediate AMD without any evidence of neovascularization, and in these situations the fluid is typically found anterior to drusenoid PED or confluent drusen and in the crypts between adjacent confluent drusens, and this is said to occur due to failure of the pump function of RPE over a large drusen, which is not able to remove the subretinal fluid. To recap the salient points, neovascular AMD is characterized by macular neovascularization, which damages retina and retinal pigment epithelium from bleeding and exudation in the active stage and scarring in the inactive later stages. Patients present with symptoms of blurring of central vision, central or paracentral scotoma, and metamorphopsia. On examination, clinical signs which may be found include macular hemorrhage, grayish-green membrane, RPE tear and scarring, as well as a pigment epithelial detachment, which may be a serous pigment epithelial detachment with or without a notch, or with or without an overlying hemorrhagic spot, fibrovascular PED, or hemorrhagic PED. Type 1 MNV originates from the choriocapillaris and lies in the sub-RPE space. Clinically, it may appear as an irregular elevation of the retina and RPE or as a notched serous PED. On fluorescein angiography, it usually appears as an occult MNV which fluoresces in the mid to late phase but not in the early phase of the angiogram. And the fluorescein angiographic subtypes of occult MNV include fibrovascular PED, late leakage of undetermined source or LLUS, or a serous PED with an area of leakage at a notch in its margin. On ICG, type 1 MNV usually appears as a well-demarcated hypercyanescent hotspot or plaque which may be found at the margin of a hypocyanescent PED. On OCT, type 1 MNV can appear as a region of shallow and irregular RPE elevation which may show a multi-layered appearance, or as a region of sub-RPE hyperreflectivity at the edge of a serous PED. Type 2 MNV lies in the subneurosensory space. It usually originates from the choriocapillaris but may arise intraretinally. It may be visible clinically as a grayish-green membrane. On FA, it usually appears as a classic MNV which shows a well-demarcated area of lacy hyperfluorescence in the early phase of the angiogram, followed by leakage and staining in the late phase. OCT shows a region of subretinal hyperreflectivity which needs to be separated from other causes of subretinal hyperreflective material. ICG may be able to detect a type 2 MNV with overlying blood. Type 3 MNV arise from the deep retinal capillary plexus and migrate posteriorly to the subneurosensory retinal or sub-RPE space. Clinically, it appears as a red hemorrhagic spot overlying a serous PED. FA shows a hyperfluorescent spot which often overlies a serous PED with or without cystoid macular edema. Indocyanine green angiography shows a hypercyanescent spot at the site of a type 3 MNV overlying a hypocyanescent PED. On OCT, type 3 MNV appears as a region of hyperreflectivity in the outer retina and usually overlying a serous PED and often associated with cystoid macular edema. OCT also reveals the presence of subretinal and intraretinal fluid in neovascular AMD and is extremely useful in monitoring the disappearance of that fluid as a response to treatment of neovascular AMD. OCTA can show the location of the MNV by appropriate segmentation. Unlike fluorescein angiography, OCTA does not show leakage. OCTA can also show whether the vessels in the neovascular complex are immature or mature and thus their potential response to therapy. OCTA is helpful to diagnose non-exudative neovascular AMD by detecting the MNV, exudative non-neovascular MNV by ruling out MNV, and can also differentiate between the various causes of SHRM. Complications of neovascular AMD include subretinal hemorrhage, RPE dip, macular atrophy, and macular scarring. Subretinal hemorrhage usually has a more irregular boundary and a lighter red color than sub-RPE hemorrhage. FA shows blocked choroidal fluorescence with visible retinal vessels overlying the hemorrhage. RPE tears occur with PEDs which are usually more than 500 microns in height and often following intravitreal anti-VEGF injections. On fluorescein angiography, RPE tears show hyperfluorescence in the region of the bare choroid and hyperfluorescence in the region of scrolled up RPE. OCT shows a discontinuity of RPE usually at the margin of a high PED, with the PED having a corrugated contour. Choroidal transmission is increased in the region of bare choroid and reduced beneath the corrugated margin of PED. Fundus autofluorescence shows hypoautofluorescence in the region of bare choroid and hyperautofluorescence in the region of scrolled up RPE. Disciform scar appears as a well-demarcated region of yellowish-white lesion with or without pigmentation, which shows late staining on fluorescein angiography but without any leakage, and on OCT it appears as a hyperreflective tissue in the outer retina and subretinal space, generally without any intraretinal or subretinal fluid. Anti-VEGFs are currently the gold standard of therapy for neovascular AMD. VEGF is secreted by hypoxic tissues and promotes neovascularization as well as vascular leakage. Available anti-VEGF drugs include ranibizumab, bevacizumab, aflibercept, brolucizumab, and faricimab. Treatment regimen can be either fixed interval regimen, prodenata or PRN regimen, and treat and extend or T&E regimen. Serious ocular side effects of anti-VEGF therapy include endophthalmitis, sterile intraocular inflammation, traumatic cataract, retinal tear and/or detachment, and retinal pigment epithelial rip. No definitive evidence of increased incidence of systemic thromboembolic events following intravitreal anti-VEGF therapy has been found. Thank you for listening.